السلام عليكم طلابنا الأعزاء. نبدأ وياكم محاضرتنا الرابعة لهذا اليوم، وإن شاء الله حتكون الأخيرة عن الثايرويد ديزيز. حتكون محاضرتنا اليوم عن الثايرويد lump أو الثايرويد swelling. الثايرويد swelling it's presented to us either as a solitary nodule or multinodular goiter or as a diffuse goiter. Okay? Most commonly it affects the women more than the men, and the majority of thyroid nodule are impalpable. Majority can be seen by investigation like ultrasound or CT scan or MRI or PET scan. Okay, the thyroid swelling or thyroid enlargement can be subdivided into three main categories. The first category characterized by diffuse goiter. Diffuse goiter, as we mentioned in the previous lectures, either it is simple goiter or Hashimoto's thyroiditis or Graves' disease or drug-induced like in amiodarone or iodine deficiency like in endemic goiter or other type of thyroiditis that is mentioned previously. Or it is a multinodular goiter, okay, or solitary nodule, which is the main constituent of our lecture today. The solitary nodule, it is either benign, like in colloid cyst, or it is hyperplastic nodule, or it is a follicular adenoma, that is benign tumor, or it is a carcinoma, like in papillary carcinoma, or follicular carcinoma, or medullary thyroid carcinoma, or anaplastic, which is rare, and lymphoma, or it is metastasis from other type of a tumor to the thyroid gland. This is an example of single thyroid nodule. As you can see, this is a big thyroid nodule, which can be seen visibly or can be visible by naked eye. In most of cases, it is painless and can be seen accidentally by neighbor or friends. While in multinodular goiter, as we see in the previous lectures, the multinodular goiter, it is lobulated like this picture, and in cases of diffuse goiter, whole gland is involved and whole gland are enlarged, but there is no definite nodule can be seen. There is no lobulation in the thyroid gland. All the thyroid gland is enlarged, and it is easily discovered by swallowing, asking the patient to swallow, and can we see the swelling of the thyroid gland. The ultrasound finding is important to differentiate between whether the nodule is benign or malignant from its characteristic. Like in this picture, we can see that this is the nodule. That is part of it. It is isoechoic or hyperechoic. There is microcalcification, and there is a cystic lesion. This is a cystic lesions inside the nodule. This another type of nodule, and this is another type of nodule. The nodule in ultrasound, we should differentiate between whether it is benign or malignant. This is the role of a radiologist. From its characteristic, like presence of halo surrounding by halo, which is a black discoloration surrounding the nodule. This is mostly goes with benign. But if the border of the nodule is irregular, and if it is containing of microcalcification inside it, or there is hypervascularization inside the nodule, these or other features, this is goes with the malignant nodule rather than the benign nodule. So the ultrasound finding is important to differentiate between benign and malignant. This is another example of thyroid nodule, which is single. It is, as you can see, that it is mainly isoechoic to hypoechoic. Hypoechoic mean that there is the color of the nodule is more with black, while if it is in comparison with the normal tissue, this is a normal tissue. Okay. And this is a CT scan. As you can see that this is a transverse section, and you can see this is the trachea, and this is the thyroid gland here, and this is the nodule. Okay, this is the thyroid nodule. And in MRI also we can see this is the thyroid tissue, and this is the trachea, and this is the esophagus, and this is the nodule inside the thyroid gland. And by giving an contrast media, it is taking an contrast, and so it may be a malignant nodule. This is an example of MRI, which can be seen in this picture. Okay, this is the thyroid nodule, and in this picture also. Okay, sorry. Okay, this is the PET scan. PET scan, positron emission tomography scan, which is important in staging of malignancies and for follow-up of malignancy for any metastasis. And if we can see, this is the trachea and this is the thyroid nodule, mean that there is invasion of the thyroid gland, maybe primary or maybe secondary from other tumor. And in this biopsy, and if we after we take the biopsy from this nodule, the biopsy show that this is the Hürthle cell carcinoma, which is a type of thyroid cancer. So from this introduction, we can differentiate whether the thyroid nodule, either it is palpable, which is seen in 4 to 8% of adult women, which is palpable, and the other percentage, which is 92, 96, is impalpable. Okay, and 1 to 2% only palpable in men. This is in women and this is in men. So the most common nodule can be seen by investigation like ultrasound or CT or MRI, as we mentioned previously. Thyroid nodule may be noticed by individual himself or herself, or by a friend or relative, as we mentioned previously, and sometimes presented as acute painful enlargement. Sometimes, maybe if it is sudden, maybe associated with pain. Okay. How can suspect that this nodule may be a malignant? We have a characteristic features or characteristic finding. If it is present, whether in the history or examination or in the finding, may increase the possibility of malignancy rather than the benign. If the nodule present in the childhood or adolescence, this is mostly goes with the malignant rather than benign. Or there is a history of head and neck irradiation. Any radiation increase the possibility of thyroid cancer rather than the benign nodule. And if it is present in the elderly, so the two extremities, the children or adolescents and the elderly, make the possibility of malignancy more. The presence of cervical lymphadenopathy, if it is present, it most goes with the thyroid malignancy. And if there is a secondary deposit from renal or breast or lung carcinoma, if the patient has previous history of renal or breast or lung carcinoma, and the nodule is usually painful and rapidly growing, or it is mostly solitary thyroid nodule, this is goes with the secondary metastasis, or this is a malignant tumor. The thyroid nodule, if it is identified by PET scan, at about 33% chance of being malignant rather than it is a benign nodule. The differential diagnosis of thyroid nodule, we should differentiate it if it is seen by naked eye or during examination, should be differentiated from lymphadenopathy. As we can see in this picture, this is the site of the thyroid gland. Okay, this is normal, and this is the enlargement of the lymphadenopathy, cervical lymphadenopathy. We should differentiate it from the thyroid nodule. Here, the thyroid gland is normal, and we should differentiate from branchial cyst. Branchial cyst, which is usually present in the lateral side of the neck, and should differentiate from dermoid cyst. Dermoid cyst is a cyst that is developed in the skin rather than in the thyroid tissue per se, although it is anteriorly present, but we can see by ultrasound that it is separated from the thyroid tissue and should differentiate from thyroglossal ductal cyst or thyroglossal duct cyst. How can differentiate this from the thyroid? As you see here, the side of the thyroid tissue, and this is the site of thyroglossal duct cyst. By examination, we ask the patient to protrude the tongue. If the nodule is elevated upward, this is goes with the thyroglossal cyst, while if it is not increased or it is elevated upward, this is mostly of thyroid tissue. Okay, and with the thyroid gland, we ask the patient to swallow, and it is move with the swallowing rather than with the protrusion of the tongue. That's seen in the thyroglossal cyst. This is an example of ultrasound finding that thyroglossal cyst can be seen here. This is the thyroid tissue, and this is the thyroglossal cyst. Okay, it is separated from the thyroid gland. As we mentioned previously, that the ultrasound scan is very important to differentiate between benign and malignant tumor from one side, and to differentiate from other differential diagnoses like lymphadenopathy, thyroglossal cyst, or dermoid cyst, or others. And also, we can see the characteristic of the nodule, whether it is benign or malignant. The other investigation important in thyroid nodule is the thyroid scintigraphy. In thyroid scintigraphy, as we can see in this picture, we can see this uptake is normal, but there is no uptake here. The absence of uptake is mean this is the cold site. The cold site mean this is a hard nodule, or it is mostly goes with the malignant nodule. While in the Graves' disease, the whole gland is involved and take take the scintigraphy. While in this picture, we can see that there is a hot nodule here, and this is multinodular goiter mostly, and this is a suspicious of a cold nodule. In thyroiditis, as we see in the previous lectures, the radioactive iodine is not uptake from the thyroid gland, so there is no uptake. And in the single autonomous nodule, the nodule take the scintigraphy, and the other tissue or of the thyroid gland is suppressed, not intake the dye. While in hot nodule, we can see this is a single thyroid nodule of hot uptake, which is maybe autonomously functioning, and the other part of the gland is take limited amount of scintigraphy. So scintigraphy very important to differentiation. The technetium scan is most important than the iodine scan, scintigraphy. Technetium scan, here we can see that there is no uptake, which is mostly goes with the cold nodule. The another subject, which is a toxic adenoma, uh, we mentioned this differential diagnosis of hyperthyroidism in the previous lectures, but here, because it is an important differential diagnosis from thyroid nodule, it here autonomously secrete excess thyroid hormone and inhibit the endogenous TSH secretion. So the patient presented with feature of thyrotoxicosis, and there is atrophy of the rest of the thyroid gland sometimes, or there is no uptake, as in this case. As here, there is uptake and the other is suppressed, or as in this case. Okay, it's more common in female, especially female more than 40 years, and diagnosis by scintigraphy, as we see previously. The thyrotoxicosis is usually mild, and in almost 50% of patients, the plasma T3 alone is elevated, which is called T3 thyrotoxicosis. And this treatment of choice in this case is radioactive iodine in about 4 100 to 800 millibecquerel, or it is which is highly effective to eradicate or to suppress the functioning of this adenoma. Or sometimes the lobectomy if the adenoma is large size, or it is causing a pressure symptom, or it is recur after radioactive iodine. The another important subject here is to differentiate the non-functioning adenoma through the thyroid neoplasia. Here we can concentrate on malignant thyroid tumor, which can be differentiated into three main categories. Either it is follicular cells, it is the tumor coming from the follicular cells, which is either differentiated or it is undifferentiated like anaplastic. And differentiated, the most common is papillary type thyroid cancer or the follicular cancer. The papillary carcinoma it constitutes about 75 to 85% in frequency, and the follicular carcinoma 10 to 20%, while anaplastic or undifferentiated carcinoma is less than 5%. The other type, which is non-follicular, which come from parafollicular C cells, which is called medullary thyroid carcinoma, and this constitutes about 5 to 8%. And the other is lymphoma, which is less than 5%. We can remember the histology of the thyroid gland. We can see that this is the thyroid follicle, which is constituted of epithelium, thyroid epithelium. This is the thyroid epithelium, which is composed of follicular cells, as we can see here. And this is the parafollicular cells, parafollicular, which is not surround the follicle. Parafollicular cells, which secrete the calcitonin, and it is called C cells. And the tumor from the C cells called medullary thyroid carcinoma, and from epithelium caused epithelial, or which is either follicular or papillary carcinoma. The papillary carcinoma, which is the most common type, as you can see here, it is constitute the picture like papillae. Okay, as you can see here, like a papillary protrusion. Okay, this is the most common type of carcinoma, and this constitute about more than 90% of radiation-induced thyroid cancer, those who are exposed to head and neck radiation, whether doctors or para medical staff. It is multifocal and spread, and the spread is initially to the regional lymph nodes. So if we catch a lymph node enlargement, it is most and the biopsy show the malignancy. It's most commonly to be a papillary type of carcinoma. Sometimes cervical lymphadenopathy can be present in patient without an thyroid enlargement if the lesion is less than 10 millimeter. Here, the prognosis is very good because we can interfere before it is metastasis to the other part of the body. The other type of follicular carcinoma, here it is usually a single tumor, single adenoma, usually encapsulated lesion, and the spread not to the lymph nodes, because the spread to the lymph nodes is rare. The most common spread or the metastasis to the through the blood bone, and are most often found in the bone or lung and brain. The picture here show that the papillary or follicular carcinoma here, to differentiate it from the follicular adenoma, it's sometimes difficult. Here the follicular, and this is a follicular, but here a carcinoma, and this is an adenoma. This is a benign and this is a malignant. The differentiation between both of these are the invasion of the wall of the thyroid tissue. If there is involvement of the wall, this is goes with the carcinoma rather than benign adenoma. The management of thyroid carcinoma need teamwork with the surgeon to remove the the thyroid gland and the lymph nodes, and need endocrinologist and need oncologist, pathologist for documentation of pathology, and radiologist. Radioactive iodine we can take after surgery, and nurse specialist. The large tumor usually need total thyroidectomy, followed by large dose of radioactive iodine, approximately 30 or 100 millicurie. The long-term treatment with levothyroxine in a dose sufficient to suppress TSH, and the dose may need 150 microgram to 200 microgram to suppress the TSH, because the TSH, if it is present, may induce the growth of any remnant part of the thyroid gland if it is present. While the smaller tumor uh, with no adverse histological feature may require only thyroid lobectomy. The follow-up through the examination of the thyroglobulin, which should be undetectable if there is total thyroidectomy, because thyroglobulin mean that there is a thyroid tissue present. But if the thyroglobulin is absent, this is mean that the thyroid tissue is absent. And thyroglobulin antibody should examine at the same time with the thyroglobulin level, because its presence may interfere with the assay. Okay. If there is a detectable level of thyroglobulin in the absence of assay interference, and there is no thyroglobulin antibody, but there is a thyroglobulin, this means a suggestive of tumor recurrence or metastasis. And the prognosis is usually very good, mostly in patient with papillary and follicular thyroid carcinoma will be cured with appropriate treatment, and it is poor only in old age, or in patient with distant metastasis, or in male, which is carry a poor prognosis, and in certain histological subtypes. The another type of thyroid carcinoma is anaplastic carcinoma, which is undifferentiated carcinoma, or non-follicular or non-papillary thyroid carcinoma. The anaplastic carcinoma usually occur in old age people, more than 60 years, and the thyroid enlargement is usually rapid with a short period, over 2 to 3 months, and the goiter is usually hard in consistency in examination. And the patient may complain from stridor due to tracheal compression, and hoarseness of voice due to recurrent laryngeal nerve palsy due to compression, either direct compression or invasion to the recurrent laryngeal nerve, and the pressure on the trachea causing a stridor. There is no effective treatment for anaplastic carcinoma, and the prognosis is very poor. And the surgery and radiotherapy may be considered for palliative treatment. In older patient, median survival is only 7 months. While in lymphoma, which is a rare but it may be present in pre-existing Hashimoto's thyroiditis, and is better because it may be a type of non-Hodgkin lymphoma, and the median survival of about 9 years. And the treatment here usually with combination of chemotherapy and external beam radiotherapy rather than radioactive iodine. Here, then, this is an example of lymphoma in patient. This is an uh, picture of thyroidectomy, and this is a CT scan for thyroid gland enlargement that's encased the trachea, and this is a histology which composed of lymphoid tissues. The other type of malignancy, which is medullary thyroid carcinoma, and tis occur from or tis come from parafollicular C cells of thyroid tissue, and tis usually secrete serotonin, calcitonin, secrete calcitonin, and sometimes secrete other elements or other substances like 5-hydroxytryptamine or serotonin that give and features of carcinoid symptoms, or sometimes secrete ASTH, ectopic ASTH, that cause Cushing syndrome. And usually the patient presented with thyroid mass and cervical lymph node is common, but distant metastasis is rare. Okay, this is an example of medullary thyroid carcinoma, which is present not in the follicular tissue but in the parafollicular cells. The treatment of medullary thyroid carcinoma is through the total thyroidectomy with removal of regional cervical lymph nodes. All the region of cervical lymph nodes should be removed with the thyroidectomy. Why? Because the tumor is coming from C cells that does not concentrate iodine. So the radioactive iodine of no benefit, and there is no role for radioactive iodine, and there is no rule to suppress the TSH because it is not a TSH dependent tumor, and there is no rule for suppression of levothyroxine, and the levothyroxine just to given to the patient in order to replace the thyroid function. And thank you very much for listening.